Here we are, Real Recovery Talk. I am your host, Tom Conrad. In today's episode, we've got Benjamin B.
What's happening, everyone?
And Dr. T.
What's going on?
First things first, thank you for tuning in on the podcast app, whichever one that you choose to use, and thank you for watching on YouTube. In the end, if you have any comments, questions, or concerns, you could always reach us, info@realrecoverytalk.com. Again, it's info@realrecoverytalk.com, and ultimately, we want to help you turn your mess into your message, right, Ben?
Correcto mundo, Tom.
It's so weird.
I had to throw that one back in. I haven't used it in a while.
Okay, so Ben, you're here. Tell us, how'd you do at your bodybuilding show?
I made a respectable appearance.
Yeah?
I'm definitely proud of my accomplishment. I won't get crazy with the explanation.
Please don't.
I did put a little 9-minute video up for all the gym rat bodybuilder people that might want to know the details.
Where?
On my Facebook, on my personal Facebook. Explaining like all the things that went right, all the things that went wrong. At the end of the day, I had a great time. I met Mr. Olympia, Derek Lunsford. Got to talk with him personally, got a selfie. And I placed third in the Masters, which is like the old guys, 35 and up.
How many people were in that class? 4?
Easy, Tom.
I'm just
Easy,
kidding.
Tom. Easy. So it ended up
kidding.
being the largest show in Florida's history. There was
Oh, wow.
237 competitors, 550 if you include the crossovers. So at the end of the day, this contest was literally stacked with competition. I couldn't have picked like a harder caliber of show to go into, but at the end of the day, it was an awesome experience, and I know now where I stand, and I will say that I do have the potential to win a show like that without a doubt. So I just need my conditioning to be better, which is, if you're interested in the science behind that part, you can check out my personal Facebook.
And where would they find that?
Under Ben Bueno, I think. Is that my Facebook?
I don't have Facebook, so I don't know.
Get the mic closer to you.
Sorry.
I think
That's
it
all right.
automatically uploaded to Instagram, too.
I didn't see a 9-minute video of you.
It was an actual post.
Okay.
Yeah. All right. Check it out.
Well, you should have let me record it for you. What'd you do? Just use your phone?
Yeah, in the truck, like Sam Sulik does.
Oh, okay.
Oh, okay.
Yeah.
All right. Well, if you want to, if you have any interest on knowing how Ben Bueno's first bodybuilding show went, or second. You can find it at Ben Bueno's Facebook page.
First one was 2009, and I was still in active addiction.
Yeah.
So this was like a totally different experience.
Good. All right. Well, Dr. T, thank you for joining us again.
Thanks for having me.
I know we were talking about some things before pressing record, and we had decided to talk about MAT. MAT is an acronym for medically assisted treatment. So, I think it's definitely a hot topic. It's a controversial topic. There's a lot of debate that can go around it. And we're here to just give you the facts and our opinions on MAT. But we're going to be specific to around opiates because MAT can kind of cross-reference across different. What am I trying to say here?
Families of drugs.
Yes.
Yeah.
Yeah. So when somebody hears MAT, medically assisted treatment, oftentimes, the drug that is closely associated with that is Suboxone. Okay. And Suboxone is something Ben and I have been very open about in the past. And if you want to hear our opinions on Suboxone, you could find them in the past episodes. There's probably a dozen or more that we talk about our opinions on it.
Yeah, I have personal experience with being on Suboxone and methadone, and we cover all that stuff, but I think it was really important to bring Dr. T on here today to give more professional medical view on it.
Well, Dr. T is coming on every week.
Well, yeah, for sure.
Every week.
Yep.
And we need to get to a point of putting it, I want to do 3 episodes a week. So 1 dedicated to Dr. T and then the other 2 how we would normally do it.
Okay.
So we got to start getting some episodes in the can so we can, you know what I mean? Mm-hmm. All right. Well, Doc,
Okay.
tell us about Suboxone.
All right. So I think let's first start with just the basics from a medical standpoint. So opiates, they act on your opiate receptors in your brain. There's different subtypes of opiate receptors, but the main one that we are going to be speaking about is the mu opiate receptor.
Mu?
Like
mu.
Like that cow behind you, Tom.
That's a bull. That's a water buffalo.
Oh my
yeah, that's
gosh,
right.
we did this already.
Okay.
And so whenever you do opiates, whether it's, heroin, fentanyl, oxy, morphine, Dilaudid, any of those substances, they act on those receptors. That's what makes you feel good. And that's when you start building tolerance. And when you use opiates, your tolerance just kind of skyrockets, right? It just straight line up. You need more and more and more to get the same desired effect. And that's, how you get the physical and eventually, in some people, the mental addiction. So when you say Suboxone, the active ingredient that we're going to be speaking about is buprenorphine. Buprenorphine also is in Subutex, Suboxone, Subzolve, all different names for the same medication.
Subzolve? I've never heard that one.
That's another one. So it has the buprenorphine in it. So the buprenorphine itself is a partial opiate agonist. What does that mean? In layman terms, basically it has a much higher affinity actually for the opiate receptor. So it grabs on harder than actual opiates like heroin, fentanyl, Dilaudid, etc. do. But because it's a partial agonist, it has kind of like this ceiling effect. So instead of going straight up, it kind of goes like this, right? And it levels out at a certain dose. So after a certain milligram, you don't get any more, upward effect of it, right? And so that's like the layman term definition and how they work in the body between the two.
So Suboxone, Subutex, Subzolve, these things, are those more just brand names? Mm-hmm. And then the actual, how did you word it? The ingredient?
The active ingredient. So you have buprenorphine itself.
Okay.
So Suboxone, Subzolve, they have naloxone in it. So some of the pills come just buprenorphine itself, by itself, which would be like a Subutex like tablet.
Okay.
Or they come in a combination of buprenorphine, naloxone. Naloxone is an opiate blocker, right? It's the same thing that we have, what Narcan is. The reason for some of the medications to contain the naloxone combination in it is to prevent diversion. So it's there to prevent patients that do get prescriptions and to try to prevent them from like crushing it, snorting it, watering it down, injecting it, because technically when you do those things, it should activate the naloxone, and the naloxone will then block the effect of the buprenorphine if it is diverted, right?
So
does that make sense?
Yeah, buprenorphine in and of itself can get you high.
It can get you high, yes. Technically, you're not supposed to use that term, get you high. It hits your opiate receptors.
What do you mean you're not supposed to use that term?
Because you're not supposed to feel high. Like whenever we prescribe these medications, it's harm reduction.
Well, right,
from our standpoint.
So can I
it's part of my argument.
I totally understand where you're coming from. I think if I put it like in my street terms as someone that's had it, my experience with it as someone that doesn't understand it medically to your level is that I kind of look at it like for somebody who has zero tolerance to opiates, they've maybe never done an opiate in their life other than maybe what the dentist gave them one time. If they took a buprenorphine-based medication such as Suboxone, they would absolutely feel
Something.
that good effect.
Yeah, like if I took one.
If you took one, you would be high.
No,
Now-
Ben, it would latch onto my opiate receptors.
Correct. Yes. So, but the way that I see it, because when I was hooked on heroin and had a really high tolerance to heroin, Suboxone didn't get me high. Buprenorphine didn't get me high because my tolerance was made me feel normal again. So I think that like when I look at an addict and they're like, oh, buprenorphine doesn't get me high, they're telling the truth because they've already got a tolerance to some other substance that really brings them up. So, but if you give it to somebody with no tolerance, but then there's that cap that you were talking about, ceiling, if you will. So you can't, it maxes out, so to speak.
So yeah, usually you're not going to see people prescribing like over 24 milligrams, a day of a daily dose. And that's a really high dose.
So which one is just buprenorphine?
Subutex, like they come in tablets. That's usually what we use to help detox patients off, like in the detox setting. Some patients do have an allergy to naloxone, or where they either get like swollen legs or they've had
that was me, doc.
Sores in their mouth or whatever that is, and so they'll say I can only have buprenorphine itself.
Oh, but do you honestly believe that?
So it's all history based. We do, if again, every setting is different, but if it is in the outpatient setting, I like to see some documentation from a physician that has taken care of the patient in the past and has notated that allergy to try to, not say that the patient's trying to be manipulating me or manipulative of the situation, but I would like to see that documentation for the most part.
So oh my gosh, there's so many brand names. Subutex, right, is just buprenorphine. Suboxone and Subzolve is buprenorphine and naloxone. So Suboxone and Subzolve are, for the sake of this conversation, the lesser of the two evils because it has the naloxone in it. It's going to be, you're going to have a less likelihood chance of being able to abuse it. But the Subutex you could abuse because it doesn't have the naloxone in it.
Right.
And you could essentially have it latch onto your opiate receptors better.
The reason for that is if patients get just Subutex by itself, they, can technically like crush it, snort it. I've had people inject it IV, and there's no blockade that happens there.
Have you done that, Ben?
So I never tried. I did try to put Suboxone in a syringe once, and I was like, it was like chalky. Now, buprenorphine, prior to Suboxone and Subutex, I actually, way back, probably around 2002, there was one called Bufrenex, which was literally liquid buprenorphine that I got in these little vials, the glass vials, and you crack them. And I would shoot those.
Okay.
Jesus.
So it was straight liquid buprenorphine. That was the original.
Well before my time.
That was before Suboxone came out. And I didn't even know what it was. I just had a friend who had fibromyalgia and just got prescribed everything under the sun. She's like, hey, I got this Bufrenex stuff.
Wow.
And you're like, screw it. Let me just shoot it up.
And that was an intramuscular injection. But I put it in my vein like any good addict.
Wow. And what was the result?
I felt good.
Okay.
It latched onto your opiate receptors.
It latched onto my opioid receptors.
Okay. Opioid receptors, yeah.
As much as I have personal experience with this stuff, I didn't realize that the naloxone blocked the actual buprenorphine. I thought it just blocked the other ones, like the heroin and the fentanyl. And because the whole thing with Suboxone and the reason it's less likely to use the word diversion, that's the proper terminology. When I would take Suboxone, when I did get heroin and I tried to use it, like I was able to inject it obviously physically, but it kept me from feeling the heroin. So I basically like wasted my heroin. And that was super annoying as a drug addict.
But that's because the buprenorphine is like 100 times stronger for that opiate receptor than the opiates themselves. So you will see that patients will use and they won't, get high. Nowadays, I mean, even before, but addicts are very smart and they do their research and they, to their credit, they look things up, they read, there's YouTube, there's all these things now that they know if you do enough heroin or fentanyl now, it's more so fentanyl, that it can overcome that block like the buprenorphine, and it will basically, if you do enough fentanyl, it'll hit the buprenorphine off the opiate receptor, and then they can get high. And they're just flooding their opiate receptors to block, like to hit off all those buprenorphine.
I'll say this too: as far as pharmacology goes, they do really make an effort to make these drugs less abusable. Like when I first for me, again, going back to the Buprenex, it started out as liquid, injectable was the only way to do it. Buprenorphine. Then was the Suboxone pills, which is why I mentioned like the powdery.
They still have those. Or not pills, I'm sorry. They have Suboxone tablets.
Tablets, yeah, that's the proper terminology. And then now they have the film, which the film is even safe.
What's that, like a Listerine
less
strip?
abusable.
Very similar.
Very similar.
Very
yeah.
similar. They put it under their tongue and you wait for it to dissolve.
That's crazy. I mean, it seems like a lot of work. So people would actually, why not just not take your Suboxone and use fentanyl?
That is the age-old debate, right? I mean, go ahead. I can go into the, like, from a medical standpoint, what criteria I try to use and how to apply it, but
Let's hear that, because that's why we brought you. Like, what's the medical criteria?
So realistically, in a vacuum, in a perfect world, there is the ideal patient to put on Suboxone maintenance, right, is going to be someone who is just in that vicious cycle. They can't stop using. Maybe they've overdosed a bunch of times in the last few weeks, 6 months, and they're at risk of dying. And as a last resort, in terms of harm reduction, that you're like, okay, we have to do something different at this point, because if they tried abstinence-based and they keep going through the cycle of treatment, use, overdose, keep using treatment, and once they're in that cycle, you got to do what you can do to break it. Ideally, that's the person who you would want to talk about Suboxone maintenance with.
Do you have, I know the answer is going to be no, but in terms of your experience, as far as age, who you see is more, or who you're going to be more comfortable doing Suboxone maintenance, or is it kind of across the board? Doesn't matter.
It doesn't matter. It's just everyone's different. You will see, though, like earlier in patients who are in the detox residential, like withdrawal management setting, those patients are more apt to want to go on Suboxone maintenance because they're detoxing and they're feeling bad and they're really craving, and they're at that like 2-week mark, and they're majority of those patients, they want to feel better. They don't want to keep going through what they're going through. So they're more apt to ask for it or want to explore it and get education on it.
I'm glad you brought up like the ideal patient, so to speak. And you mentioned like the patient that we have to do something for. Because like if I speak for myself and my experience, both with methadone and with Suboxone, I wanted to be sober at the time, but I truly believe for whatever reason I was incapable of doing so at the time. So methadone in particular brought my tolerance to opiates so high, I didn't stop using heroin when I was attending the methadone program. I think I passed my first drug test because I got out of detox, and then continued to use heroin while I was on the methadone program. But the methadone brought my tolerance so high that I could have overdosed, but like I wasn't overdosing because my tolerance was so high. Suboxone, same kind of thing. Like I do believe that methadone and Suboxone kept me alive until I was capable of complete abstinence and being sober. So like, while for me, I don't think there's any argument, like the best way to go is the best possible outcome is abstinence, point blank period. I look at it like if somebody had diabetes and they had a way to reverse it and never do insulin again, that would be the best possible outcome. Right. Now, if someone needs insulin the rest of their life, okay. But I would definitely have to say, like, it played a part in my life at a time, and it kept me alive until I had the chance to really get sober.
Right.
So.
What's the, I mean, we talk a lot about Suboxone, Subutex, Subzolve, all these fancy ones. What about methadone? What is that? Like, what's the difference?
The difference is obviously the half-life of it. It's very, very, very long-acting.
Methadone is?
Methadone is very long-acting. And, the difference is also access. So here in South Florida, there's not many methadone clinics. It's very regulated by the government. The facilities that have their license to do methadone, they only have X number of outpatient facilities that you can have in each county. And so it's very difficult to get. There might be outside of South Florida. I'm sure it's very different, no matter where you go. But at least here, you don't see many methadone clinics or patients on methadone anymore. The whole point behind methadone was also harm reduction. But I'll be honest, when you have patients that are on methadone and then you get them because they're trying to come off or their chronic relapse are on methadone, it's really difficult because methadone's half-life is so long and it's stored like in, various tissues in the body. So it keeps releasing for such a long period of time that the withdrawal management of it can be like a month, even after a month. It's really hard on patients.
Methadone was hands down the hardest drug for me to ever get off of. I was so physically addicted. I was on 120 milligrams for probably a year and a half. And the worst part is I had a federal exemption letter because I'm an addict manipulator. You're supposed to go to the clinic every day and get it and drink it in front of them.
Right.
I got this federal exemption that I had poverty issues and couldn't make it there, so they gave me take home. So I was just injecting it straight out of the bottle into my arm. Yeah. And my tolerance was so high. Coming off of methadone was the worst thing in the world. Absolute worst. And I was going into that because I wanted to ask you too. You had mentioned buprenorphine grabbing onto the receptors stronger than other opiates. Mm-hmm. Is there, scientifically, medically speaking, a harder withdrawal off of methadone and Suboxone, Subutex, than there is, say, heroin and fentanyl, since it grasps on so tight?
It's longer. So usually you'll see, depending on what they're using, the half-life of each of fentanyl, heroin, oxy, codone, Dilaudid, the half-lives are very different. And when it gets out of their body, you have your short-acting and your long-acting, which as a spectrum should last anywhere from like 3 days, maybe to a week. But definitely with methadone, first of all, whenever in these withdrawal management inpatient facilities, we usually say we need the patient to be tapered down to, between 60 and 40 milligrams before they even come in, because it's going to take another week or two before they even start feeling any withdrawals from it. And then it's usually another 2 weeks after that you're trying to manage them through, and then probably another 2 weeks after that. The buprenorphine is less than methadone. I'd say it's in the middle, between just coming off opiates itself and methadone. It's like the lesser of the two evils.
I will say this, just as someone that has to be familiar with being able to refer out, when we get calls and when people, and it's fewer and far between, like you said earlier, methadone's not like it used to be. But when you do get a call for somebody on methadone, there are very few detoxes that will even take methadone patients, period. And like you said, they generally have to be brought down a little. One other thing I wanted to bring up too, from the medical perspective, correct me if I'm wrong, the benefit to putting somebody on a long half-life opiate is it's more of a consistent.
Yep.
So like, I'll use heroin or fentanyl as an example. They have a very short half-life. So that's why you get that really high, but then you go in withdrawal so quick. Where I think the idea or theory behind Suboxone, methadone is like it just keeps an even state where there's not high up and downs. It's just more. That's
the goal, is to keep them on that like plateau where they're just not up and down, up and down. They're kind of even. So they're not having, the goal is to not have the patient have breakthrough withdrawal symptoms, craving, so they can manage their life and get through their day-to-day and function and get back into a routine, from using or whatever they were doing.
Which makes sense. So if somebody takes it as prescribed without deviating from the plan that their doctor has, they're, like you said, not high because they've got that tolerance. They're just riding straight across in a way that they're not having cravings. And that's ideally, if, like you said in a vacuum earlier, if everybody followed the protocol that their doctor wrote for them, it would work.
Yeah.
Great every time, I think.
Like SAMHSA, the governing body of addiction and with ASAM, et cetera, realistically, if patients are doing Suboxone maintenance, you're supposed to have a clinical team, so a therapist in conjunction with your physician who's writing for it, because a lot of times you'll find like a doc in the box just writing scripts for Suboxone, but realistically, those patients still need all of the other services that other patients need. They still need to do their therapy. They still should have a sponsor. They should still be going to meetings and working their steps and doing everything they're supposed to do. And, I know that technically that model is not for every single patient, but even when we are taught with prescribing it, that's in a vacuum how it should look with your patients if you are prescribing it.
Let me ask this. It's kind of maybe a little bit off, but I have heard very rare instances of this, but sometimes when someone has a legit pain management program, like that would be put on a oxycodone or Vicodin, I have heard of a couple people being prescribed Suboxone for long-term pain management. Is that accurate?
They do pain management. So they have buprenorphine patches, but they also use buprenorphine itself for pain management. Pain management physicians do.
Do you consider that a better alternative than like a Vicodin or an Oxy?
I mean, that's a dicey topic because I'm not a pain management physician trained physician. So there may be studies out there in pain management that I don't know about. But again, I think it is the lesser of two evils if you are going to do pain management in terms of diversion, the addiction, and needing more and more of the standard opiates to get the same desired effect to mitigate their pain. So I would if I was a pain management physician, but I know every patient's different.
Well, I think it would depend on the severity of the pain too, as far as if you're going to take buprenorphine versus OxyContin. Like if I chop my leg off, I'm probably not going to want to mess around with some, give me the good shit. Really.
But I mean, to answer your question, like the ideal candidate, you want to make sure that, the patient has the funds to pay for the medication. So whenever I start someone on Suboxone maintenance, my first question is like, are you working? Do you have enough money to cover your co-pays for the medication itself? Do you have enough money to continue your outpatient doctor visits and therapeutic visits? What is their home life like? Are they living in halfway? Are they homeless? Do they have a good support system at home? Because that also makes a difference, right? Is the family involved? Is it something early on that you want to make sure you do random, pill or tablet or strip counts, when the patient comes in? Are there urine drug screens? How often are they? Are they random? Are they observed? So all of those things go into play or should go into play when people write for it.
And the question is does it? That's the...
I don't think they have this challenge anymore, but, I've been sober for 13 years now. And back when I was on Suboxone, one of the things that I ran into pretty regularly, I would say every other month, sometimes every third month, I'd be out of my Suboxone, go have my appointment, even when I was taking it as prescribed, which was rare, but I would get to the pharmacy and they would tell me, hey, the truck's not going to be here for another 3 days. There used to be back in my day, like Suboxone shortages, and I'm like out, and I'm like, and then I get sick, and I'm like thinking to myself, really, that's what ended up in the end for me, steering me away from Suboxone, is I was living in constant fear back then of I could be out one day and the pharmacy might not have it for a week, and then it's just as if I'm, for me, coming off of heroin.
Right.
I'm like, I don't know that they have that problem anymore because Suboxone is more relevant.
It is. It's more, pharmacies still have it, but you will still get pharmacies that don't carry it, or they're like, hey, we have to order this. It's going to be a couple days. Try our other store, CVS, Walgreens. But we're lucky down in South Florida, in essence, because we are the hub of treatment in this area. So a lot of smaller mom and pop pharmacies do carry it and have it. So the access to it is a lot easier nowadays.
My next question is, if you have 100 clients in front of you and all of them are requesting sub-maintenance, how many of them do you think truly
need it?
Yeah.
Oh, that's a tough question.
Another loaded question, Tom.
I would probably say a handful, a very small percentage.
Yeah.
But if you ask, by the book addiction medicine, they would say
all of them,
right? And that's the difficult part with physicians is you are taught this in school and you take your test and this is what they want to ingrain is like harm reduction for all, which I agree with, and harm reducing, but I don't necessarily believe that every single patient should just automatically get placed on Suboxone, because you'll see in the hospital if those physicians are pushing it, you're not asking the patient about what are you going to do when you discharge. So you get a patient in the hospital, they overdose, you put them on Suboxone maintenance, they feel good, everything's fine. You give them a prescription, and then what? They can't afford the prescription. They're homeless. Their family doesn't want to help them. And then now they're withdrawing from buprenorphine. So what's the next thing they're going to do? They're going to go use and probably overdose. So it's all relative to what you're doing and also the patient at hand.
Well, my idea of harm reduction, and kind of to take it back to Ben's references in terms of diabetes, like I love harm reduction. I don't want anybody to be harmed. I want to reduce the harm.
Yes.
If I don't want anybody to have to go through that. But with that being said, I think that it begs the question of, okay, am I doing harm reduction or am I just prolonging the harm? And that is something that I wrestle with. I agree 100%. I don't want people to die. And if it's a matter of keeping you alive, by all means, go for it. But what I struggle with is seeing a 22-year-old young man or young woman who, comes across MAT, sub-maintenance or whatever the case is, and there's no end in sight, and this just becomes the new normal. Because in my opinion, what we are doing there, it's not doing harm reduction. You're just prolonging the inevitable. They're going to have to come off of the Suboxone, and the longer that they're on the Suboxone, the harder it's going to be for their detox. And the harder that their detox is, the more likely that they're going to go back to using their drug of choice. So for me, a true harm reduction would look like, hey, okay, if you're insistent on, and you could speak into this, if you are insistent on going on Suboxone, before we even agree that we're going to do this, what does this look like? And well, you kind of just answered this a little bit ago. What are the steps we are going to take? First off, I'm not putting you on Suboxone longer than 30 days or 45 days. This whole 6-month Suboxone maintenance bullshit, I'm not doing that. If I was a doctor, this is what I would do. And in these 30 or 45 days, and mind you, I would do this the same when it comes to Xanax, Ativan, because we're using this to cope with your anxiety. I'll give you a 30-day or a 60-day prescription of Xanax, but in those 60 days, this is what you're going to do to deal with your anxiety, because I'm not giving you another script of it. If you want another one, go to another doctor. What's the plan? What are you going to do to work on why are you using the drugs? Why do you feel the necessity to be on the Suboxone? What are the pros and cons in your mind of abstinence-based treatment? You've gotten a sponsor before and it didn't work out. Well, why not? And let's try a different one. Vast array of different things that we can do. But everybody just jumps on this. Well, it's MAT. It's keeping me alive. So fuck it. I'm just going to keep doing it. And it doesn't make sense to me. And let me just say this last thing. And this goes back to the diabetes thing. Everybody is like, oh, go on insulin and people buy into the idea. I'm just going to stick myself with an insulin pen every morning. And, if I know I'm going out tonight for a birthday party, I'm going to take a little bit more extra insulin with me so I can have some cake. How often, and this is a question for you, and Ben, don't forget what you were going to ask, but like because you treat other people other than drug addicts and alcoholics, you see normal people. Mm-hmm. From a doctor or a physician's perspective, if somebody comes across your desk and they're diagnosed, their new diagnosis of diabetes, how much lifestyle education is given into that? Obviously you can't say, hey, I'm only going to give you insulin for 60 days. Right. We're going to give you insulin until you don't need it. But how much effort is put towards,
Unfortunately, in today's society, the importance should really be on that diet, lifestyle, exercise, education. But, these people have been, and it very, very parallels addiction. It's a chronic disease that has ensued over time. And these patients are oftentimes do not have insight into how bad their disease is,
right?
Whether it's addiction or diabetes. So, like to our prior podcast, we have 15 minutes with the patient. How much education do you think can be done?
Yeah.
When I sit with a patient with new onset diabetes that needs insulin, that means they are so far in their disease, right, that they are on insulin, and that's a big deal. It's a big lifestyle change for them that is going to have to ensue to get them off of insulin. So, same thing, we refer to nutritionists. You have to try to the American Heart Association says that you should exercise at least 30 minutes a day, 5 days a week. What does exercise mean? Does that mean walking, running on a treadmill? What is my heart rate, right? So how can you explain all of this in a 15-minute visit? And so that's like the same thing. You have a 15-minute visit with an addict and you're just trying to tease through, how bad is their addiction? What is the end game, both sides of it? Right. What are you going to do every time you see them, whether it's every 2 weeks or every month? For me, it's a check-in. What did you do differently? What did you change? Did you do any type of exercising? Did you see a dietitian or a nutritionist? I often refer people to Weight Watchers because they have support groups. They have you can have a one-on-one life skills person, you can get a personal trainer. So often things we see in treatment, right? You get a sponsor, you go to groups. So these are the things you check in with, both sides of it.
Yeah, there's a lot of commonalities there.
I mean, that's where I was going with it. I doubt in that 15 minutes, if you're prescribing someone insulin for their first time, you're like, I'm giving you this insulin so that you can continue to eat McDonald's 5 times a day.
Right.
And I brought this up last podcast, but just to hit the point home, that's why I love having you in particular here at Rock, because you're a good example of a healthy lifestyle too. You sit down with our clients and you help prescribe, but at the same time, obviously you work out. Our clients see you show up here with your meal preps and you're eating your meal preps in front of them. Are you showing me that?
Oh, no.
Oh.
No.
Tom broke something.
No, I didn't. I'm just it's
Here's a
my
piece.
it's like my my fiddler thing. My fiddle.
Fidget called?
Spinner.
There you go.
Yeah.
But my point comes to this is at the end of the day, the client has to be willing to change.
Yeah.
And, a doctor can have all this training and be as good as Dr. T with the dictionology and all that. And it's like getting a personal trainer. Your personal trainer can write you a program all day. If you don't do it,
Right.
you're not going to get the result you want. And that's the bottom line. Yeah. If they do what she says, they're going to end up good.
We had a nutritionist come in here a couple years ago. My God, it was embarrassing.
I mean, think about it though. For most of our population, they don't even know how to grocery shop, right? Or even budget. Or so it's, and I shouldn't even just say our population. That goes to the general population.
Mm-hmm.
Patients come in with diabetes. Maybe it's economic reasons they can only buy certain things, but it's more education. Like if you sat with someone who showed you what you could buy with $40 at the grocery store, then you can make a difference in their life. But it's education and breaking those barriers.
Let me get away from the diabetes thing for a second, and because I want to ask about one that we didn't bring up, Sublocade.
Heck, I was going to talk about that.
So, was it? We've only had one experience at Rock with this, or was it our second?
No, recently, I think we just had the one.
So we recently had a client who was prescribed Sublocade at a previous center, and I'll let you explain what Sublocade is.
So the new class of medications that's recently come about, they're called long-acting injectables, okay? Sublocade has, become king of the hill on that, and Sublocade is buprenorphine. It comes in a, liquid or oil-infused injection, and it's subcutaneous. When you inject it, it turns into a hard ball. And it's not a big ball. It's like maybe 1 ml or 1.5 ml of solution. And once it hardens, it then releases very slowly over the month. So the shot is every 30 days. So the goal is to push patients to do this shot because, once you get multiple injections in over 2, 3, 4 months, they've hit that steady state. And one, they're not married to, going to the doctor to get their strips or to the pharmacy. And, they don't go through that acute withdrawal if you miss a strip or two, right? They did studies to show the blood levels of buprenorphine with sublingual buprenorphine versus the injectable Sublocade. Okay.
What's sublingual? Is
that's
oral?
how the underneath the tongue.
Okay.
That's how the buprenorphine sublingually it's taken.
Yeah.
The tablets, the films. So the study showed that the strips and the tablets themselves only reach like a nanogram concentration of like 2 nanograms, right? Then you have Sublocade 300 milligrams, which it's usually that's your first 2 months shots are 300, and then you drop to 100 after that, right? Because you kind of load the patient. The 100 milligram got their blood levels to like a 3.2, so higher than the strips, right? So the level is higher in their blood. The 300 milligram got their blood level to like a 6 nanogram level. And then they did a study on top of that. They gave patients fentanyl to try to basically overdose them. And I know it sounds...
Where was I to sign up for this study?
It sounds really...
These are the studies I looked for in Minnesota when I was up there. Like they had crack smoking studies and stuff.
Oh, really?
Oh, yeah.
Okay. Well, it sounds like really
How do I get
inhumane.
involved?
But with the 300 milligram dose of Sublocade, no amount of fentanyl overcame that.
Really?
Yeah. So that's why now...
No kidding.
So that's why now they're trying to push more people to the long-acting injectables. And I feel more comfortable doing the long-acting injectables because, if they're on that 300 milligram concentration, they should be relatively safe.
How long has those been out?
It's been probably in the last like 2 to 3 years.
Really?
But it hasn't been as available.
It's not as available because, with insurance, it's been difficult.
It's more expensive, probably.
So access is becoming more.
Let me, just to make sure I heard that clearly, in layman's terms, people weren't able to overdose on fentanyl when they were on
The 300 milligram injection of Sublocade.
Wow.
I mean, that sounds pretty useful. And that goes back to not being able to divert, because once it's injected, it's injected. One of the things that we ran into, because again, this is newer and we're abstinence-based program, we had a guy that wasn't honest with us about his last injection and how many weeks prior it was. So when he arrived to us, all of a sudden his drug test is lighting up for buprenorphine. And there was some small jumps, but what we weren't prepared for, like, I guess my question is, the only way to divert would be to take more buprenorphine on top of it, like through an oral, sublingual. Or what effect does that have, if any?
So in the beginning, when you're loading the patient, there are some patients who say at like between the 21 to 28 day mark, they do start like their first shot or second shot withdrawal symptoms. And it can occur just because of the way that the half-life of it. So those patients, some very limited few, we give sublingual buprenorphine to hold them to their next shot. But most of the time that's like when they're in a program. It's really difficult to do like in an outpatient setting. It would be more in, like a PHP, IOP setting or a really good outpatient clinic. But once they get that like second shot, they should be at a real steady state that they shouldn't really feel any type of breakthrough withdrawal. And I've had patients, most of the time they'll get like 3, 4, 5 shots. And then they're like, I don't want to do it anymore. I actually feel really good. I'm in a good place in my life. I'm doing all the things I'm supposed to do. And they usually do fairly well with it. They will experience some withdrawal down the line, 2-3 months down the line. But it's very minimal, maybe a little bit of GI symptoms, a little bit of sweats here and there, but it's nothing like missing a strip, mid prescription.
That's what I was going to ask. Like, is there withdrawal at any point?
Because there are UAs, if you do subsequent injections, most patients will still test positive for buprenorphine like 6 months down the line, 6, 7, 8 months down the line. Because that's the point of it, is that when it goes into your subcutaneous tissue, it turns into a hard ball and then it releases over time. So
I like that example you gave where the person was like, oh, I don't really want to do this anymore. I'm in a good spot in my life. Because really that's what methadone and Suboxone did for me. Was I didn't get sober right away after that, after those. But being on both those things, I wasn't reaping the benefits of the highs because I had the tolerance. But I was like, because of the physical dependence, it became really annoying. And like when I wanted to go on vacation, I'm like, do I have this? Do I have that? What if I miss this or lose that? And I think as part of my process and having willingness to change, I was like, man, I really want to be off everything, because they refer to methadone in particular back in the day as liquid handcuffs.
Yeah.
Like if you had to go to the clinic daily, you couldn't leave your city. You couldn't go to Disney World. Like you had to tell your family, no kids, I can't take that trip. Daddy has to be by the methadone clinic. Like,
right.
And that got not cool.
Right. And also with Suboxone, patients don't realize it, but they get it becomes habit. You have to wake up, you have to put the strip under your tongue. It's like a safety blanket in essence. And then they get into this routine where they're doing it for months. So to break that actual habit, like all things being, equal, that's another habit that's very difficult to break too, because you then have that mental aspect with it.
Well, that was fun.
Yeah, that was good. I'm glad we dove more into the science behind it. Tom and I just always kicked it on our street lingo for this boxing and methadone stuff.
Give me the 30-second version of naltrexone and Vivitrol.
So 30-second version, naltrexone's the oral pill. Vivitrol is the long-acting injectable form of naltrexone once a month, kind of parallels buprenorphine. It's actually an opiate blocker. So it's not an agonist. It doesn't activate the receptors. It blocks the receptors. And the theory behind that is that it decreases the reward, right, that you get, but it also blocks the opiate receptor. So if you try to get high while on it, it should block it shouldn't allow the opiate to get to that receptor. Patients are smart. They know they can do enough fentanyl to overcome the blockade. Patients can overdose. So there's pros and cons to naltrexone as well. In an abstinence-based program, we do try to educate and push naltrexone, but I'm honest with people. Like, up out of the gate, yes, this will block you from getting high, but I have had patients who have overdosed and died on me, and I feel horrible because of that. So I just try to be honest and open from the start and just let them know what they're getting into walking into it.
They're prescribing naltrexone for weight management now.
They are.
Yeah.
And naltrexone is Narcan. So in essence, right? Mm-hmm. So in essence, it's like taking Narcan every day.
Narcan is naloxone. It's like a sister to naltrexone. We don't have to get into the.
Oh, I thought they were just different name brands. No, they're different.
The pharmacology behind it, but
anyways,
yeah, naltrexone. It's an opiate blocker.
Yeah, don't go too science on me. I
gotta go pick my daughters.
Yeah, I could go on about that. So,
well, thanks for coming on, T. Dr. T. Ben, any final thoughts?
No, I always have fun doing this.
All right, well, next week. We need some questions, people. info@realrecoverytalk.com, right? Mm-hmm. All right, that is it for this episode of Real Recovery Talk. Thank you for tuning in. In the end, if you have any comments, questions, or concerns, you can always reach us and ask us your questions at info@realrecoverytalk.com. Again, that's info@realrecoverytalk.com. And ultimately, we want to help you turn your mess into your message, right, Ben?
Yeah, what's with you today?
I know he's tired.
I'm tired, and I rolled my foot playing basketball. That is it. We will see y'all later.